Dialysis patients could be dying from this, and nobody talks about it. This mistaken practice in dialysis could be deadly. Most dialysis nurses and technicians get this wrong. Are you one of them? I'm Abby, the dialysis guy. Alright, let's address a big controversy today. Should oral antihypertensive medications be taken before hemodialysis? There's a lot of debate on this topic, and today we'll look at both sides of the argument. On one side, the common logic goes like this. If we give antihypertensive meds before dialysis, it might lower the blood pressure too much. And we all know that one of the most common complications of hemodialysis is intradialytic hypertension, low blood pressure during treatment. But here's the catch. If blood pressure drops too much, it can lead to serious complications, even death. But here's the counter-argument, and it's backed by research, not just my opinion. Studies, like the Take and Hold study, have shed light on this issue and presented some surprising findings. In this cluster randomized trial, dialysis units were split into two groups. One was instructed to take all BP meds as prescribed, and the other was told to hold medications for those taken more than once daily before hemodialysis. The goal? To see if taking the medications could be as safe or even better than holding them. The results? Well, taking the medications was not inferior to holding them for preventing asymptomatic intradialytic hypertension. In fact, taking the meds actually reduced uncontrolled hypertension and kept patients from having excessively high blood pressure before dialysis. But here's where things get complicated. While taking the meds helped with blood pressure control, it didn't change the occurrence of hypertension during dialysis. Now, I know this might sound confusing. Should we hold the meds or take them? The key takeaway from this study is that taking the meds doesn't worsen the primary issue, intradialytic hypertension, but it does lower the risk of uncontrolled high blood pressure, which is another dangerous issue in dialysis patients. So, while some argue that holding medications is essential to preventing low blood pressure, there's growing evidence that suggests not withholding antihypertensive medications before dialysis can lead to better overall blood pressure management. And of course, we need to tailor this to each patient's specific needs. Let's also remember that dietary sodium restriction, appropriate medication choice, and newer treatments like spironolactone and chlorthalidone can all make a difference in managing hypertension in dialysis patients. And new blood pressure-lowering drugs like oxygenone and aprocitentan are under investigation for their potential to improve patient outcomes. Research-grade blood pressure measurement is no longer just for research, it's for everyday practice. Accurate blood pressure measurement in dialysis is essential for individualizing treatment and preventing complications. Dietary sodium restriction can improve blood pressure in individuals and provide low-cost public health benefits, especially for patients with chronic kidney disease. Now let's talk about medication choices. ACE inhibitors or angiotensin receptor blockers remain the first-line choice in pharmacotherapy for hypertension in patients with chronic kidney disease and very high albuminuria. However, spironolactone, while being the standard of care treatment for resistant hypertension, comes with the risk of hyperkalemia, which limits its use in patients with moderate to advanced chronic kidney disease. The thiazide-like diuretic chlorthalidone, on the other hand, is very effective in improving blood pressure control, even in patients with an estimated glomerular filtration rate of less than 30 milliliters per minute per 1.73 square meters. This makes it a viable alternative for managing resistant hypertension in advanced chronic kidney disease. It's also important to note that discontinuation of ACE inhibitors or angiotensin receptor blockers in patients with advanced chronic kidney disease, especially those nearing the initiation of dialysis, does not stabilize the long-term decline in kidney function. So the idea of discontinuing these medications could be harmful in the long run. Personalized treatment should always be the goal, and the initiation and intensification of antihypertensive therapy should be guided by blood pressure measurements taken under standardized conditions, as recommended by guidelines. Consider dietary sodium restriction as a key component of hypertension management, especially for patients with chronic kidney disease. And when selecting antihypertensive agents, you must take into account the presence and severity of albuminuria. For patients with high albuminuria, ACE inhibitors or angiotensin receptor blockers should be the first choice, unless there are contraindications. For patients with moderate to advanced chronic kidney disease and resistant hypertension who can't tolerate spironolactone, the administration of a potassium-binding polymer may help reduce the risk of hyperkalemia, allowing for continued use of spironolactone. If spironolactone isn't an option, chlorthalidone is a strong alternative. But as with all medications, careful monitoring is crucial for preventing adverse events, especially in those with advanced chronic kidney disease. Finally, beta blockers are not typically recommended as first-line treatments for hypertension, but they do have a role in treating chronic kidney disease patients with specific indications, like heart failure with reduced ejection fraction or post-myocardial infarction. So, to wrap it up, the practice of withholding antihypertensive medications before dialysis may not be the best approach for everyone. The Take and Hold study shows us that we need to focus on a balanced strategy with personalized treatment that takes blood pressure management into account. Thanks for watching. I'd love to hear your thoughts on this. Let me know what you think in the comments below. I'm Abby, signing out. Cheers.